Good afternoon, doctors. This is a case of a 71-year-old man with loose bowel movement. I am PGI Cabo, and let us begin. For the identifying data, the patient is a 71-year-old male married Filipino Catholic. A businessman coming from Balanghiga, Eastern Samar, with a chief complaint of loose bowel movement and hematochezia. Was admitted last January 27, 2021 at 4:30 in the afternoon. His history of present illness started 3 days prior to admission, wherein he noted onset of brownish tinge, loose watery stool, occurring 3 to 4 times per day, associated with crampy abdominal pain. He took loperamide 2 mg tab 3 times a day, affording slight relief of symptoms. However, 6 hours prior to admission, he experienced moderate to severe epigastric pain with a pain scale of 8 out of 10. It was followed by defecation of brownish, watery fecal material, approximately 600 to 800 cc in amount. It was also followed by dizziness, prompting now his relatives to bring him to Balanghiga District Hospital, wherein he was subsequently referred to our institution, hence admission. For his past medical history, he had a recurrent epigastric pain for the past 7 years with previous admissions. He also underwent endoscopy and colonoscopy 2 years ago with unrecalled results. He had an unremarkable family history. He is also a smoker with 23 pack years and also a moderate alcoholic beverage drinker. ROS was not given, so we proceed with physical examination. So he was seen conscious, coherent, in slight respiratory distress with the following vital signs. He was hypotensive with a BP of 80/60 mm mercury, tachycardic with a heart rate of 117 beats per minute and tachypneic with 26 cycles per minute. His temperature was 36 degrees Celsius, which was decreased, and also he was hypoxemic based on his autosaturation of 93% at room air. His skin was cold, clammy, poor turgor and capillarity feel. He also had a pale palpebral conjunctivae with slightly sunken eyeballs, anecteric sclerae, and dry lips and tongue. For his heart, he was tachycardic, and there was note of positive hemic murmur. So a hemic murmur is a loud presystolic murmur at the apex. So it is heard when aortic regurgitation is preventing the mitral valve from closing. It is also called as Austin-French murmur. It is due to an abnormal, commonly anemic condition of the blood. For his abdomen, there was positive direct tenderness at the epigastrium with muscle guarding on palpitation. He also had a normal active bowel sounds. And for his extremities, it was grade 1 pulses on all extremities. Now, I present to you the salient features of the case. So, he's a 71-year-old male, Filipino, from Balanghiga, Eastern Samar. From his history, he had a chief complaint of loose bowel movement with hematochezia. So, he also had a brownish tinge, loose, watery stool occurring 3 to 4 times a day. He had a severe epigastric pain, 8 out of 10. With fecal material approximately 600 to 800 cc in amount, and was also followed by dizziness. From his past medical history, he had a recurrent epigastric pain for the past 7 years, which sometimes he was admitted. He is also a smoker with 23 pack years and a moderate alcoholic beverage drinker. For his physical examination, he was hypotensive, tachycardic, tachypneic, and with signs of anemia presented here in the table. Now, given with all these salient features, I now present to you my differential diagnosis. First, I have acute pancreatitis. So, I ruled in acute pancreatitis because of the presence of epigastric pain, the changes in bowel movement, the patient being alcoholic beverage drinker, and also the presence of tachycardia and hypotension in the patient. However, I ruled it out because there was no note of the characteristic pain of acute pancreatitis, which was the epigastric pain, which relates to the back and it was relieved by leaning forward. Also, there was no nausea, vomiting, and abdominal distension. Also, there was no colon sign. Another differential is acute cholecystitis. I ruled in acute cholecystitis because of recurrent epigastric pain and also the patient's age, which was a high risk for acute cholecystitis. However, I ruled it out because there was no colicky abdominal pain, there was no Murphy sign, there was no fever, nausea, vomiting, or even jaundice. For another differential is acute gastroenteritis. So it is common among elderly, 71-year-old male. Um, I've also ruled it in because of the presence of LBM, abdominal pain, the sunken eyeballs, dry lips, and dry mouth, which are signs of dehydration. However, I ruled it out because there was no nausea, vomiting, and the patient was afebrile. The most common cause of acute gastroenteritis in this age group is infection or infectious etiologies. However, there were no fever. Also, the patient had normal active bowel sound, and there was presence of tenderness, which cannot be seen acute gastroenteritis. Another differential is ruptured acute aortic aneurysm. I ruled it in because of sudden onset epigastric pain and also severe pain. The patient had 8 out of 10 pain rating scale, and also because of the age of the patient, and also because he is a smoker. So these are the risk factors for abdominal aortic aneurysm. However, I ruled it out because the pain was actually not very sharp, which is characteristic in a ruptured abdominal aortic aneurysm, and there was no associated nausea and vomiting, and also we did not find any palpable pulsatile, expansile, non-tender abdominal mass. Another differential diagnosis is aortic dissection. So I ruled it in because of epigastric pain and also because of the age of the patient. However, I ruled it out because of the characteristic pain was not present in our patient. Moving forward, another differential diagnosis is acute or rather gastric adenocarcinoma. I ruled it in because of epigastric pain, the patient's age, and also because he is a smoker. Also because there was changes in bowel movement, the presence of hematochezia, and signs of anemia. So I ruled it out because there was no weight loss, anorexia, early satiety, and also there was no family history of adenocarcinoma in the patient. Another differential to consider is pancreatic adenocarcinoma. I ruled it in because of epigastric pain, the changes in bowel movement, the age of the patient, and also the risk factors like alcoholic beverage drinker and smoker. However, I ruled it out because the pain is not characteristic of pancreatic adenocarcinoma, and also there are no signs of weight loss, penis jaundice, and also there's hematochezia. So these signs do not lead to pancreatic adenocarcinoma. Another differential includes GERD, or the gastroesophageal reflux disease. So I ruled it in because the patient had epigastric pain, the age of the patient, and also his risk factors. I ruled it out because usually in GERD, we have this characteristic heartburn and regurgitation, and also metallic taste in the mouth, which was not seen in the patient. So I ruled it out. Acute appendicitis can also be a consideration in epigastric pain, especially in elderly. So acute appendicitis. Also, diarrhea can present with acute appendicitis, especially in the elderly. However, I ruled it out because there was no nausea, vomiting, anorexia, there was no rebound tenderness, no bruising sign, no fever, and also no migratory right lower quadrant pain. Furthermore, I have another differential which includes the diverticular bleeding. So I ruled it in because of acute hematochezia, which was seen in the patient, and also the age of the patient. However, I ruled it out because usually in diverticular bleeding, it is a painless bleeding. There should be no abdominal pain, and also we saw tenderness, which is not usually present in diverticular bleeding. Inflammatory bowel disease is also a consideration because of hematochezia, the diarrhea, and abdominal pain of the patient. However, we did not see mucoid discharge, and also it's lower incidence in more than 70 years old patient, and usually it is more commonly found in younger patients. With all of these differential salient features given or presented, I now present my admitting impression as upper GI bleeding from peptic ulcer disease to consider hypovolemic shock. So upper GI bleeding is or commonly presents with melena, or in cases of massive upper GI bleeding, hematochezia, which was seen in the patient. And the most common causes of GIB are, first, we have ulcer diseases, and second, we have the gastric or esophageal diseases like varices, which are usually secondary to portal hypertension. Now I present to you here a pathophysiology of how peptic ulcer disease occurs or develops. So usually we have the risk factors first. In our case, we have an elderly patient and also he had a history of peptic ulcer disease clinically as presented in the history. So if you have increased susceptibility, there is higher chance of Helicobacter pylori infection. Now what happens when we have Helicobacter pylori infection? It leads to inflammatory responses due to the virulence factor and bacterial urease it produces. So it would lead to increased gastric acid secretion, increased gastrin release, and decreased somatostatin secretion, which ultimately lead to inflammatory response that also damage mucosal or epithelial or had epithelial cell injury. So after epithelial cell injury or mucosal damage is done, it can now produce the epigastric pain which the patient felt, or also it can penetrate the blood vessels which may produce melena or hematochezia in severe cases that now leads to the signs of anemia that was seen in our patient. I also have here a better picture showing the cellular level damage in peptic ulceration. So what's important to note in this picture only is that for the injury to happen, it can be either increase the damage or assaulting factors or decreasing the defense or impairing defenses of the mucosa. It would ultimately lead to ulceration, producing now our symptoms mentioned earlier. I've also here a slide of hypovolemic shock. So in my diagnosis, I've included hypovolemic shock because of the physical examination of the patient. So hypovolemic shock can happen if there is perforated viscous, then producing now secondary peritonitis, which would produce flat, board-like rigidity in the patient or tenderness in the patient, and also hypoactive bowel sounds. The third space sequestration of fluid would lead to decreased blood volume, here hypovolemia, producing now the symptoms which was similarly found in our patient. Now what do we do at the ER? So this is important to note, especially to us interns. First, we put the patient on NPO as it aggravates the assault or the trauma to the gastric mucosa, which was presented before. We also insert large bore cannula to take out the blood for the diagnostics. We also replace fluid to ensure adequate fluid resuscitation or to correct the hypovolemia. And we may start empiric antibiotics, especially that we consider Helicobacter pylori infection. And we do other diagnostics and expectant management. So if perforation is suspected, we may request chest x-ray upright to check for the free air under the diaphragm. So we also have the risk factors for operative mortality in perforated ulcers to consider ulceration in our patient. So if there's presence of concomitant disease, preoperative shock, or more than 48 hours of perforation. So these are the risk factors for operative mortality. Now we go to surgical anatomy. So for surgical anatomy, it's important to consider the anatomy of the stomach. So the stomach has 1.5 liter capacity, and it also has 5 regions. We have the cardia, the fundus, the body or the corpus, the antrum, and the pylorus. So I have here the description of these regions. So the cardia connects to the esophagus here, the cardia. The fundus is the superiormost part, which is has crucial role in capacitance by undergoing preceptive relaxation. So it is also the site of autonomic pacemaker responsible for initiating gastric motor activity. The body or the corpus, so it's the connection from the cardiac orifice to the incisura incisura angularis or the lesser ankle. The antrum naman, it's from the incisura angularis to the pylorus and forms the distal 25 to 30% of the stomach. And the pylorus is the distal tubular part of the part with the pyloric sphincter as its muscular wall. We also have the omental ligaments. We have two, the lesser omentum and the greater omentum, which has each its own attachment or ligaments. For the arterial blood supply of the stomach, for the lesser curvature, we have the right gastric, which is from the hepatic artery proper, and the left gastric, which is from the celiac trunk. For the greater curvature, we have the right gastroepiploic. We also have the left gastroepiploic from the splenic artery. For the fundus naman, fundus is the short gastric arteries coming from the splenic artery. So what's important to note here in this slide is that in doing surgical procedures in the stomach, we have several blood supplies which affect the recovery of our post-surgical management or care. So for surgical pearl, because of the stomach's rich anatomic vascular network, at least 2 of the 4 arteries may be ligated during surgery without significant consequences. For the lymphatic drainage, it's good to know that we have several lymph nodes or drainage in the stomach. To consider to also note of the lymphatic spread, for example in cancers. So we have the superior gastric lymph nodes for the proximal lesser curvature and the suprapyloric lymph nodes in the distal lesser curvature, and also the pancreatico-splenic lymph nodes at the proximal greater curvature and the infrapyloric lymph nodes in the distal greater curvature. So we have 4. So the criminal nerve of Grassi, which supplies the posterior fundus, is easily missed during highly selective orthogonal vagotomy. So this important thing to know in this slide is the nerve of Grassi for the stomach innervation. Now we have here the histology of the gastric mucosa. So we have here the cells, surface mucous cells, which secretes the mucous layer or the protective mucous layer that contains the bicarbonate and the glycoprotein. We have the mucous neck cells, which are produce less alkaline mucous layer that contains glycoproteins and also pepsinogens. The parietal cells or the oxyntic cells produce the hydrochloric acid and the intrinsic factor, which is important for the absorption of vitamin B12. The chief cells or the zymogenic cells produce the pepsinogen, gastric lipases, and leptin. And also the enterochromaffin cells produce the serotonin, and the enterochromaffin-like cells produce the histamines. The D cells produce the somatostatin, and the G cells produce the gastrin. Okay. So, for the histology, so we have, in the stomach, we have the mucosa, submucosa, muscularis propria, and also the serosa. So, it's from the innermost to the outermost. Here, you can see it here on the right side. So, it's important to know that an intact serosa prevents the metastatic spread of gastric tumors in the peritoneal cavity. So, it has an important role of containing the spread of metastatic cancers. Okay, so we go to the peptic ulcer disease diagnosis. So we may use upper endoscopy or EGD. So young patients with symptoms may start empiric treatment, and endoscopy is indicated in all patients more than 45 years with symptoms. So with alarm symptoms, we check for weight loss, the bleeding or recurrent vomiting, and anemia and dysphagia. So upper endoscopy, we just visually check it, which is both diagnostic and therapeutic. We can also do biopsy. So all gastric ulcers and areas of gastritis should be biopsied to rule out carcinoma and H. pylori infection. H. pylori testing. So it's a test of choice when endoscopy is not indicated. Urea breath test naman is preferred for confirming cure. For histologic test is to ascertain presence of H. pylori, and the rapid urease test is the simplest method when endoscopy is necessary. The culture is done for repeated failure of medical treatment. So we have here for the peptic ulcer disease a comparison between gastric ulcer and duodenal ulcers. The usual location of gastric ulcer is at the incisura or near the lesser curvature, while for the duodenal ulcer, it's usually in the first portion of the duodenum or within 3 centimeters from the pylorus. For the age group, the gastric ulcer is more common in older age group compared to the duodenal ulcer, which is common in younger age group, with higher male predilection in duodenal ulcer, while in gastric ulcer, it has an equal sex predilection, which is 1:1. Since gastric ulcer is more common in the elderly, it has higher risk or common risk for carcinoma, and the goal of management includes gastrectomy to rule out cancer with biopsy, compared to duodenal ulcer. Now here is a slide showing the modified Johnson classification for gastric ulcer. So we have types 1, 2, 3, 4, and 5. For type 1, which is the most common, it's found at the lesser curvature incisura, here. So the acid level is low to normal, while type 2 naman, it's found at the gastric body with duodenal ulcer. Yeah, so dalawa siya, which has increased acid level, while for type 3, it's the pre-pyloric, which also has increased level, and also 4 on the high curvature, on lesser curve, and type 5, which is NSAID induced, can be found anywhere. So we also have ulcer complications. So for bleeding is the most common complication in ulcers, which can be seen as melena or coffee ground emesis. Usually, it can be found in gastric or duodenal, which is higher on posterior compared to anterior. So usually it happens in ruptured gastric ulcer and the lesser curvature of the stomach, leading to bleeding from the left gastric artery, or ulcer on the posterior wall of the duodenum, which leads to bleeding from the gastroduodenal artery. Perforation is another complication, which is the second most common complication. So it is sudden severe generalized abdominal pain, usually duodenal, condition duodenal. So there is decreased mucosal protection against acid secretion. Also, the anterior duodenal ulcers can perforate into anterior abdominal cavity, potentially leading to pneumoperitoneum. That's why it's important to have an X-ray upright. So we may see free air under the diaphragm with referred pain to the shoulder via the irritation of the phrenic nerve. The least common complication among the three is obstruction. So usually there's pain worsening with meals, and also the presence of nausea and vomiting of undigested food. So it's found at pyloric channel or can be at the duodenal. So we go with bleeding again. So for the diagnosis of bleeding, we do NGT and early endoscopy to see blood. The treatment, usually it's non-operative. First, we put the patient on NPO. We give acid suppression, endoscopic treatment. We can also do epinephrine cautery. So indications for surgery in cases of bleeding: if there is persistent bleeding or rebleeding after endoscopic therapy, there's also significant hemorrhage of more than 4 units decrease in 24 hours. Also, in elderly patients with comorbidities, indicated na siya. Ulcers located at posterior duodenal bulb and ulcers located at the gastric lesser curvature. And also high risk of rebleeding based on endoscopic findings like active pulsatile bleeding or visible vessels. So the Forest classification for endoscopic findings and rebleeding risk. We have grade 1A, which is active pulsatile bleeding, which is rebleeding high risk. So the only low risk lang among the classifications are grade 2C and grade 3. So if it's only black dot or no signs of recent rebleeding, then it is definitely has low rebleeding risk. For perforation, usually presents as acute abdomen. So there's initial chemical peritonitis, later becoming bacterial and leading to fluid sequestration. So there's marked abdominal guarding and rebound tenderness. So we ask for upright chest x-ray to check for pneumoperitoneum, which is sensitive in 80% of cases. Also, for the treatment, we do non-operative. We seal the leak without signs of peritonitis or emergency exploration. Now we go to medical treatment of peptic ulcer disease. It includes inhibition of acid secretions, smoking cessation, alcohol avoidance, NSAID withdrawal, and also eradication of H. pylori. Okay, so for H. pylori eradication, we have these therapies. We have the bismuth triple therapy, which includes bismuth, metronidazole, tetracycline, or quadruple therapy, which is the gold standard among these. We give proton pump inhibitors, bismuth, metronidazole, or tetracycline. We also have the PPI triple therapy, and also, so we give them 10 to 14 days treatment as recommended. And we also repeat esophagogastric duodenal biopsy at 6 to 8 weeks. Now for the definitions used in surgical management. We have 1 oversew, which is running with overlap sutures, for example, to treat bleeding ulcers, or oversewing of bleeding vessels. We also have the omental or Graham patch, which is the use of viable omental tissue as additional layer for suturing, which is treatment for perforated ulcers in poor operative candidates. Vagotomy, which is surgical cutting of vagus nerves to reduce the acid secretion in the stomach. And also, it is a treatment option for chronic duodenal ulcers. So the types are truncal vagotomy or highly selective vagotomy. For truncal vagotomy, so the division of the main trunk of the vagus nerve and the denervation of the pylorus. A pyloric drainage procedure is needed after truncal vagotomy because vagal nerve or vagal fibers relax the pylorus. So if the vagus is cut, the pylorus will not open and does not relax. The disadvantage is that post-vagotomy diarrhea or the dumping syndrome, which is more common with truncal vagotomy compared to highly selective vagotomy or the parietal cell vagotomy. Now speaking of HSV, the HSV vagal fibers to the body of the stomach are transected without interruption of the fibers to the pylorus. Denervation of only the fundus and the body of the stomach and preserves the nerve supply of the antrum and the pylorus. So pyloric drainage procedure is not needed, and the disadvantage is that there's higher ulcer recurrence. For the drainage procedure, distal gastrectomy or antrectomy. So that's the removal of distal portion of the stomach or the antrum. Pyloroplasty is the dilation of the pylorus, which is done to compensate for the decreased gastric emptying of the or after vagotomy. We also have the reconstruction methods. We have the Billroth 1 and the Billroth 2. Billroth 1 is truncal vagotomy plus entrectomy plus gastroduodenostomy, which connects the stomach to the duodenum, while Billroth 2 is truncal vagotomy plus entrectomy with gastrojejunostomy. Now this time we connect the stomach to the jejunum. Here. Now what are the indications for surgery in peptic ulcer disease? So we have here list in decreasing frequency. First is perforation. Another is obstruction. A third is bleeding. And lastly, we have intractability or non-healing. So perforation talaga is the number 1 indication for surgery. So what are the choice of operation for peptic ulcer disease? We have that based on the type of ulcer, is it the duodenal or gastric, the indication for operation, and the condition of the patient. So others include list here presented. Furthermore, we have more indications here. bleeding, perforation, obstruction, and non-healing ulcers. Yeah, so with these indications and also the location, it may be gastric or duodenal, we now have here the choice of surgical procedures. For example, if the patient has bleeding gastric ulcer, then we can do over-Swan biopsy, and vagotomy, and drainage, and also distal gastrectomy. Now, if the ulcer is duodenal ulcer with bleeding, we can do over-Su with vagotomy and drainage, or vagotomy and antrectomy. So we have here a guide on how we do or what surgical choice we can do. So here again, so we give emphasis on perforation because it's the number one indication of in peptic ulcer disease. So we can do biopsy and Graham patch or wedge excision with vagotomy and drainage, and also distal gastrectomy. Or if it is in duodenal type of perforation, we can do patching and highly selective vagotomy, or patching with vagotomy and or drainage. So simple patch closure is the most commonly performed operation for perforated peptic ulcer. The procedure of choice in patients with hemodynamic instability and or exudative peritonitis, signifying a perforation of more than 24 hours. Well, patch with highly selective vagotomy is done in stable patients without long-standing perforation, particularly those with chronic symptoms or failure of medical treatment. Well, patch and vagotomy and drainage is an acceptable treatment, but occasionally side effects are disabling, and also there's high chance of recurrence. Now, what about post-gastrectomy problems? The post-gastrectomy problems includes dumping syndrome, diarrhea, gastric stasis, bile reflux gastritis, Rooks syndrome, gallstone, weight loss, anemia, and bone disease. So the dumping syndrome is caused by the destruction of the pyloric sphincter, causing abrupt delivery of hyperosmolar load to the small intestine. So early dumping is at 15 to 30 minutes postprandial. There's peripheral and splanchnic vasodilation that leads to shock-like symptoms like sweating, lightheadedness, and tachycardia. And that is also relieved by saline or recumbency. The medical management includes octreotide. Well, for late dumping naman, which is 2 to 3 hours postprandial, is due to hyperinsulinemia with reactive hypoglycemia. So it is relieved by glucose administration, and the medical management is alpha-glucosidase inhibitors. So, in dumping syndrome, we avoid liquids during meals and also high-fiber diet. For surgical treatment, we can do conversion to Roux-en-Y anastomosis. We also have the Roux-stasis syndrome. So for its pathophysiology, it results from functional obstruction due to disruption of normal propagation of pace setter potentials in the Roux limb from the proximal duodenum, as well as altered motility in gastric remnant. The clinical manifestations characterized by chronic abdominal pain, nausea, and vomiting, and that is aggravated by eating. The diagnosis includes upper GI series that confirms these findings and may show delayed gastric emptying. Endoscopy may show retained food or reservoirs, dilation of the gastric remnant, and or dilation of the Roux limb. GI motility testing shows abnormal motility in the Roux limb with propulsive activity toward rather than away from the stomach. Now, the management includes non-operative, which is the use of pro-motility agents, or surgical, which is near total or total gastrectomy to remove the atonic stomach. Now, this would be the end of my slide. Thank you very much for listening.